A very good morning to one and all. Today's topic is labeled antibody based techniques, part 2. Myself, Dr. Raghusudha, Head Assistant Professor, Department of Microbiology, Government City College from Hyderabad, is here to discuss on other two techniques of labeled antibody based techniques, radioimmunoassay and immunofluorescent assay. In the previous video, I discussed about ELISA, and this video is about radioimmunoassay and immunofluorescent assay, followed by techniques used for diagnosis of COVID-19. Radioimmunoassay. It was first developed by Rosalind Allo and Solomon Burson in late 1950s. Rosalind Allo was the first female to receive Nobel Prize in 1977. They used this technique using radioactive materials to detect tiny amounts of insulin in situ human. Radioimmunoassay requires special precautions and licensing since radioactive substances are used. It is a widely accepted and highly sensitive serological test. The reactants like antibody, antigen, or hapten are first labeled with radioactive isotopes like iodine I-123 and hydrogen H3. Let us see some of the isotopes and their half-lives and uses. Carbon 11 half-life 20.3 m, used for brain scans. Chromium 51 half-life 27.8 days, used for blood volume determination. Cobalt 57 half-life 270 days, used to measure vitamin B12 uptake. Cobalt 60 half-life 5.26 years, radiation cancer therapy. Gadolinium 153 half-life 242 days, used to determine bone density. Gallium 67 half-life 78.1 days, used to scan lung tumors. Iodine 131 half-life 8.07 days, used for thyroid therapy. Iridium 192 half-life 74 days, used for breast cancer therapy. Radioimmunoassay technique involves competitive binding of radiolabeled antigen and unlabeled antigen to a high affinity antibody. The sensitivity range is from 0.00006 to 0.006 micrograms of antibodies per ml. Labeled reactants are detected by radioautography. It is used for diagnosis of allergies, endocrine disorders, hepatitis virus, narcotics, etc. Radioimmunoassay involves three principles. The first one is immune reaction. Second, competitive binding or competitive displacement reaction, which gives specificity for the test. Third, measurement of radio emission. Even this provides sensitivity to the test. As we have discussed about immune reaction is forming a complex between antigen and a specific antibody. The second principle is about competitive binding or competitive displacement reaction. This is a phenomenon wherein when there are two antigens which can bind to the same antibody, the antigen with more concentration binds extensively with the limited antibody, displacing the other. So here in the experiment, the radiolabeled antigen is allowed to bind to high affinity antibody. Then when patient serum is added, unlabeled antigens in its start binding to the antibody, displacing the labeled antigen. Diagrammatic representation of radioimmunoassays principal competitive binding. Here in the picture we can see unlabeled hormone and labeled hormone. Here we can see unlabeled hormones which are already bound to the antibody are being displaced by labeled hormone. Once the incubation is over, then washings are done to remove any unbound antigens. Then radio emission of the antigen antibody complex is taken. The gamma rays from radio labeled antigens are measured. The procedure requires small amounts of samples and can be conducted in small 96 well microtiter plates similar to ELISA. Hence, this procedure is suitable to determine the concentration of a particular antigen in large amounts of samples. For example, a microtiter RIA can be used to screen for the presence of hepatitis B virus. Radioimmunoassay screening for donor blood has sharply reduced the incidence of hepatitis B infections in recipients of blood transfusions. Now let us see the procedure of radioimmunoassay. The labeled antigen is mixed with antibody at a concentration that saturates the antigen binding sites of the antibody. Then test sample of an unlabeled antigen of unknown concentrations are added in progressively more substantial amounts. The antibody does not distinguish labeled from the unlabeled antigen. So, the two kinds of antigen compete for available binding sites on the antibody. As the concentration of the unlabeled antigen increases, the more labeled antigen will be displaced from the binding sites. The decrease in the amount of the radiolabeled antigen bound to the specific antibody in the presence of the test sample is measured to determine the amount of the antigen present in the test sample. The antigen is generally labeled with a gamma emitting isotope such as I-125, but beta emitting isotopes such as tritium H3 are also routinely used as labels. The radio-labeled antigen is part of assay mixture. The test sample may be a complex mixture such as serum or other body fluids that contain the unlabeled antigen. In the picture we can see, in the picture A, sample antigen is incubated with primary antibodies, and in the second picture, radio-labeled antigen is then added. It competes with the sample peptide and displaces it. The picture C, secondary antibody binds to the primary antibodies and causes it to precipitate out of the solution. In the fourth picture we can see, picture D, centrifugation causes the antibody antigen complex to form a pellet. Radiation levels are inversely proportionate to the amount of the sample antigen present. Example of a typical standard curve. When a standard curve is plotted against radioactivity and the concentration, as the concentration of the antigen increases, radioactivity decreases as it displaces the labeled antigens. Drawbacks. The main drawback to radioimmunoassay are the expense and hazards if preparing and handling the radioactive antigen. Both I-125 and I-131 emit gamma radiation that require special counting equipment. The body concentrates iodine atoms, radioactive or not, in thyroid glands where they are incorporated in thyroxine T4. Uses of radioimmunoassay. Radioimmunoassays are used in detecting narcotic drugs, blood banks for screening hepatitis virus, used for early detection of cancer, used for measurement of growth hormone levels, used for tracking leukemia virus, used for diagnosis and treatment of peptic ulcers, and research with brain chemicals called neurotransmitters. Let us see the difference between ELISA and radioimmunoassay. Character. The measurement relies largely on color in case of ELISA, whereas in radioimmunoassay it is production of radiation. The key molecule in ELISA is enzyme linked to antigen or antibody. In radioimmunoassay, the key molecule is radioactive isotope. The reacting substance to produce a detectable change in ELISA is enzyme horse radix peroxidase, whereas in radioimmunoassay it is the iodine isotope. The time of experiment for ELISA is very short and one can measure very fast, whereas radioimmunoassay is very time taking. Skill requirement for ELISA is minimal, and skill and knowledge is requirement for ELISA is very little, whereas radioimmunoassay for radioimmunoassay an efficient and highly skilled handler is needed to minimize the risk of exposure of radiation. There is no special permission required for performing ELISA experiment, whereas special permissions and licenses are required for use of radioactive material. Disposal of waste in case of ELISA is similar to that what is being done along with the other medical waste, whereas for radioimmunoassay the disposal requires special care and avoid radiation exposure by other people. ELISA is applied for diagnosing diseases, many diseases due to its rapid experimentation, whereas radioimmunoassay is largely for receptor binding studies and also to small extent for diagnosis. Moving on to the next technique, immunofluorescence or immunofluorescent assay. Immunofluorescence stands for it is a powerful technique that utilizes fluorescent labeled antibodies to detect specific target antigens. Here a dye called fluorescent is being used, which emits greenish fluorescence under UV light. It can be tagged to a immunoglobulin molecule. This technique is sometimes used to make viral plugs more readily visible to the human eye. Immunofluorescent labeled tissue sections are microscope. Immunofluorescent assay was first invented by Albert Kunz in 1940. The fluorescent dyes such as fluorescent isothiocyanate and lysamine rhodamine can be tagged with antibody molecules. They emit blue-green or orange-red fluorescence respectively under UV light rays in the fluorescent microscope. Examples of fluorescent dyes. The first one is fluorescent and the second one is rhodamine. There are two ways of doing immunofluorescent staining. One is direct immunofluorescence, second one is indirect immunofluorescence. Direct immunofluorescence, it's just a simple and a very common procedure in this regard. Antigen is fixed on the slide. The fluorescent labeled antibodies are layered over it. The slide is washed to remove unbound or unattached antibodies examined under UV light in a fluorescent microscope. The site where the antibody attaches to its specific antigen will show apple green fluorescence. It is used for detecting pathogens or their antigens in tissues or in pathogenic samples. Direct immunofluorescence. So, this is how the technique goes. The tissue section containing the antigen is being placed, and to this the fluorescent labeled antibody is bound. Indirect immunofluorescence. Indirect test is a double layer technique. The unlabeled antibody is applied directly to the tissue substrate treated with a fluorochrome conjugated anti-immunoglobulin serum. So, this is the difference between direct and indirect. Direct, the viral antigen is bound to a labeled antibody, that is it. Whereas in indirect, the viral antigen is first bound to a virus specific antibody, then for example murine M antibody, and this is again relabeled with, reattached with immunofluorescent labeled anti-mouse antibody. Advantages over direct immunofluorescence. Since several fluorescent anti-immunoglobulins can bind to each antibody present in the first layer, the fluorescence is brighter than the direct test. It is also more time efficient since it is only one signal labeled reagent. The anti-immunoglobulin is prepared during the lengthy conjugation process. Uses of indirect method. Indirect method is used to detect specific antibodies for serodiagnosis of syphilis, leptospirosis, amoebiosis, toxoplasmosis and many other infectious diseases. It identifies the class of a given antibody by using fluorescent antibodies specific for different immunoglobulin isotypes. It identifies and enumerates lymphocyte subpopulations by employing monoclonal antibodies and cytofluorographs. And it also detects autoantibodies such as anti-nuclear antibodies in autoimmune diseases. Immunofluorescence may also be used to analyze the distribution of proteins, glycans and small biological and non-biological molecules. Immunofluorescence have been widely used in biological research and medical research. That is all about antibody labeled techniques. We have discussed about ELISA, radioimmunoassay and immunofluorescent assays. In the wake of pandemic COVID-19, I would like to discuss about the diagnostic techniques which have been used in detecting this COVID-19 virus. The serological tests used for detecting COVID-19 aid in investigating ongoing outbreak and retrospective assessment of the attack rate or extent of an outbreak. The cross reactivity to other coronaviruses can be challenging. The first test which can be used to detect COVID-19 is rapid diagnostic test based on antigen detection. It detects the presence of viral protein expressed by COVID-19 virus in a sample from the respiratory tract of a person. If the target antigen is present in sufficient concentrations in the sample, it will bind to the specific antibody, fixed to a paper strip enclosed in a plastic casing and generate a virtually detectable signal typically within 30 minutes. The antigen detected are expressed only when the virus is actively replicating. Such tests are best to identify acute or early infection. Efficiency of the test depends on several factors. The time of onset of the illness, concentration of virus in the specimen, quality of the specimen collected from a person and how it is tested, precise formulations of the reagents in the testing kit, and the sensitivity can vary from 34 to 80%. Drawbacks: half or more infected patients might miss such tests because this test is to be done in the early stage of infection. These assumptions urgently require further study to understand whether they are accurate. The false positive test may result if the antibodies on the test strip also recognize antigens of viruses other than COVID-19, such as from human coronavirus that cause the common cold. With the limited data, WHO does not correctly recommend the use of antigen detecting rapid diagnostic tests for patients' care. The second test, serological test, is rapid diagnostic test based on antibody detection. It tests the presence of antibody in the blood of infected people. Antibodies are produced over days to weeks after infection with the virus. The strength of antibody response depends on several factors like age, nutritional status, severity of the disease, and certain medications or infections like HIV that suppress the immune system. In some people with COVID-19, confirmed by molecular testing like RT-PCR, it is weak. Late or absent antibody responses have been reported. Studies suggest that majority of patients develop antibody response only in the second week after onset of the symptoms. This means the diagnosis of COVID-19 infection based on antibody response will often only be possible in the recovery phase. Antibody detection tests may also cross-react with other pathogens including human coronavirus and gives positive results. Hence, WHO does not recommend the use of antibody detecting RDT for patients' care but encourages its use in disease surveillance and epidemiological research. The next test is RT-PCR test. It is recommended by WHO for identification and laboratory confirmation of COVID-19 cases. The first test is NAT, nucleic acid amplification test. It is used for detection of unique sequence of virus RNA by NAT, such as real-time reverse transcription polymerase chain reaction with confirmation by nucleic acid sequencing. Discord results possibility of contamination is seen in this particular technique. Reverse transcription polymerase chain reaction produces a positive rate of detection up to 38%. Reverse transcription loop mediated isothermal amplification has similar sensitivity to RRT-PCR, is highly specific and used to detect MERS-CoV. Nasopharyngeal and oropharyngeal swab tests standard assessment is positive rate for oropharyngeal swab is only for 53.3%. The quantitative RT-PCR assay two different regions of the virus ORF1b and N. Three novel RT-PCR assay targets RNA dependent RNA polymerase, helicase, spike and nucleocapsid genes of SARS-CoV-2 have also been developed. It is highly sensitive and specific assay help to improve the laboratory diagnosis of COVID-19. Automated solutions for molecular diagnosis can handle large number of samples and can be scaled to keep pace with fluctuating demand. Millal Dhakwa Bhosle, India's first corona testing kit, was developed by her, and she developed this kit on 24th March 2020 from MyLab Life Solutions, a Pune based molecular diagnostic startup, and has received commercial approval from Central Drug Standard Control Organization to sell COVID-19 test kit. It is a qualitative PCR based kit, and the kit is named as MyLab Patho Detect COVID-19. Other methods used for detection of the COVID-19 virus. The first of it is viral sequencing. It can be useful to monitor the viral genome mutations that might affect the performance of medical countermeasures. It needs a high viral load in the clinical sample. It's not recommended as a routine diagnostic procedure. Thank you all.